Hello, everyone at Astra, and welcome to Space Doctor. When thinking about how to start a show like this, we're talking about aerospace medicine and things related. And I also like to talk a lot about history, especially the history of science. It's so fascinating. We'll be doing a lot of that on this show. And since we do have to talk a lot about air pressures and the physiology related to what happens when you change pressure environments, which is a very big part of space physiology, of aerospace medicine, I thought it would be good to start by talking about an Italian anatomist and physician who lived in the late 1600s and early 1700s, who actually has a device named for him that astronauts use inside their spacesuits. And he has a maneuver named for him that is related to the device that astronauts use inside their spacesuits. And you use that maneuver not only if you go into space, but also every time you excrete your bowels, you use it. You use it when you laugh, when you cough. You might use it if you are a healthcare provider and you're examining a patient's heart to evaluate a murmur and seeing if you can change the sound of that murmur or the strength of that murmur. I'm talking about the Valsalva maneuver, named for Antonio Maria Valsalva. So what do I mean by a Valsalva maneuver? What is that? Well, here's what it looks like. See, I am expiring against a closed glottis. What is the glottis? Well, most people have heard of the epiglottis, that little flap of tissue that kind of goes like this over the throat, over the back of the throat to protect the trachea from food getting inside or water getting inside when you swallow. So while you eat, you don't want anything going down the trachea. And the epiglottis protects against that. But we're talking about the glottis, which is when your two vocal cords come together. You got two vocal cords and they're kind of moving around as I talk right now, and they have to be open for you to breathe. But when they come together, that's the glottis, and that closes up the airway. And so there's now a disconnection. There's a seal between the upper respiratory tract and the lower respiratory tract. And when you exhale against a closed glottis, you can increase the intrathoracic pressure. That's the air pressure inside the thoracic cavity, which is the cavity, that space inside the upper part of the torso, everything above the diaphragm, which is a muscle that goes up and down, that helps you breathe. And so it in the front, it's defined by the chest wall, and the back by the back, and then you have walls around it on the side. You can also increase the pressure inside your head. And that's very useful because if you have there is a connection between the back of your mouth and the middle ear. That's the eustachian tube, which is also named for another famous anatomist who lived in that same time period of all these people like Valsalva who started to discover stuff about pressures and stuff. Blaise Pascal is another one that will come into play, and we even have units named for him, the Pascal, that we're going to mention, which is a good thing to bring up right now because you have different pressures outside versus sometimes on the inside. The outside air pressure, the atmospheric pressure, that is the force per area that is pushing on you. And at sea level, that has a particular quantity at sea level, and it goes down, the amount of pressure goes down as you ascend to higher altitudes, and it goes up if you descend. Such as, well, if you go someplace below sea level on Earth, the lowest place is at the Dead Sea in Israel and Jordan. And actually, the air pressure is a little bit higher there, not so much higher, because the air pressure doesn't change too much unless you really go up and down a lot. Now, when you go down in the ocean or in the lake or any body of water, well, then it really goes down a lot, goes up a lot, that pressure. Just 10 meters down, you're already doubling approximately the amount of pressure that's on you. So at sea level, there is a constant pressure, although it changes based on weather conditions. But the pressure is about 103 kilopascals, and that's named for Pascal. Uh, in imperial units, that is, we can use pounds per square inch. I really think that's kind of an antiquated kind of system. We should be getting off the English don't use the English system so much anymore, but engineers use it. And it's used a lot in the United States, as you know. Kind of slow to get away from metric here. Well, that would be 14.7 psi, 14.7 pounds per square inch. And you could also call that one atmosphere. That's an easy one. Remember, one atmosphere, one ATA. There's another little variation on that, which is atmosphere is absolute. Sometimes as we go to very high pressures, we talk about um, number of atmospheres above the normal, what you're normally feeling. So it can get a little complicated. And how many other units a week we did? We did kilopascals, we did atmosphere, we did PSI, we did atmospheres. And there are other units, and people also use sometimes centimeters of water. And then a very important one that we will use a lot is millimeters mercury. And the normal atmospheric pressure, meaning at sea level, corresponding to about 103 kilopascal, comes out to 760 millimeters mercury. And so those are numbers, you don't have to memorize them, but we'll repeat this a lot. This is going to come up on other episodes. Now, if you're going up and down, you will feel this very easily on the tympanic membranes inside your ear. The tympanic membrane is a membrane that separates the external auditory canal, which is in continuous communication with the atmosphere. So the pressure there, if you were at sea level, would be 760 millimeters mercury. Separates that from the middle ear. And the middle ear can be in contact with the oral pharyngeal cavity. But normally the eustachian tube is closed. Now, you can open it up though with the pressure by doing a Valsalva maneuver. And there's a stronger way to do a Valsalva maneuver than when I did it. You can hold your nose if you really have to open up that tube, and then you can kind of feel a pop. Now, don't do this at home unless you really have practiced it and know what you're doing. If you're just at sea level and you don't have a pressure difference, meaning you don't have high pressure pushing on your tympanic membranes from the outside, and you really go all out doing a strong Valsalva maneuver, you could actually injure your tympanic membranes. You can cause barotrauma. But preventing barotrauma is what you want to do if you're going to a higher pressure, and you'll really start to feel it, and it could lead to a perforation. And that would be barotrauma causing a perforated tympanic membrane. When does that happen? Well, it happens if you go scuba diving, and as you go down, you will really feel that pressure. If you've done diving, you know, and you've learned this in the training, how to do this. You have to be able to clear those ears. And that's why if you have an upper respiratory tract infection, it could be really painful and hard, and it can actually it could rupture your eardrum, your tympanic membrane. Um, you also feel this in an aircraft when the aircraft is getting ready to descend. When you are up in the sky, the pressure is lower than when you're at sea level or at whatever the altitude of where you started out before you took off. Now, that doesn't mean that the pressure inside the plane is is the same as the outside atmosphere, because you can only go up uh, to, there's a certain limit how high you can get before you'll pass out, because not only is the total atmospheric pressure going down as you go up, but so is what's called the partial pressure of oxygen, of O2. Now, when we talked about how at sea level we have 760 millimeters mercury, what that really means, that's the total of all of the gases in the air pushing on your body, but they're not all the same gas. Most of that, about 78% of that, is nitrogen. And only about 21% of that is oxygen. But the oxygen partial pressure, which at sea level comes out to about 160 millimeters mercury. Oh, that's about 21% of the 760. You can tolerate down to lower pressures of oxygen to say 110, maybe 100 is kind of pushing it, and you'll pass out. And that corresponds to going up, certain number of meters, like 3,000, 4,000, something like that. Um, Maybe 5,000, depending on your training level and your level of fitness. You will get to a point above which you will pass out if you don't breathe supplemental oxygen, or if you're not in a pressurized aircraft. Now, you are in a pressurized aircraft if you're in a commercial aircraft, if you're not on a passenger flight. If you're in a But if you're in a 787, a Boeing 787, for instance, there's a pretty decent amount of air pressurization. It does not take you to sea level pressure. With a modern 787, you're pressurized to the equivalent of something like 1,800, 1,900 meters. Okay, in imperial, that's about 6,000 feet equivalent. So it's as if you were at that altitude rather than being way, way higher, such as at 14,000, 15,000 meters altitude, where you wouldn't be able to, you would lose consciousness at that pressure, the pressure corresponding to that altitude. But the plane, in other words, is partially pressured. And that means that when you start to descend, the pressure will go up. Now, so how does that come out? How does it come out in terms of what the actual pressure is? We said it's the altitude equivalent, being at, let's say, 1,900 meters. That's about 9.06 pounds per square inch, PSI. And it's something like 62, 63 kilopascal. So it's about 60, 61% of the normal air pressure that you feel when you're on the ground. And that's plenty. That's enough that for most people, except people who have certain pulmonary conditions, who might actually need to fly with supplemental oxygen, it's perfectly fine for anyone else. Even pregnant women who don't have any other health issues can get by on a long flight, and there won't be any danger from not having enough partial pressure of oxygen as a result of having a total pressure of air down below normal. Although it's advised if you are pregnant or if you're sort of on the borderline for any other reason, if you are flying and you land and you're changing planes, if you have a chance, go outside, breathe in some fresh air. That's always a good thing to do. Plus, it's really good to move around. There are other reasons. When you're on a long flight, anybody is at risk for what's called a deep venous thrombosis, uh, uh, but especially particular people. Smokers, which nobody should be anymore, but there still are at elevated risk for DVT. Pregnant women, especially near the end of pregnancy, and actually about 6 weeks after that, high risk. Also, women on oral contraceptives, and do not ever combine being on oral contraceptives with being a smoker. That's a no-no. There, the risks add up to more than what you would get from multiplying the two risks together. Absolutely contraindicated. But I digress because we're really talking about air pressures. We're not really here to talk about blood clots. We will be doing that in other episodes. Now, when the plane is ready to descend, you'll start to feel the pressure on your tympanic membranes, and you can do a Valsalva as you get down. If you know how to do it with your nose, that's the time to do it. If you don't have a cold and everything's working okay, you can often just Valsalva pretty easily without doing this. But you will get an idea that the plane is starting to descend because that's the time when all the babies and the toddlers start crying, wah, wah, because they don't know how to do a Valsalva maneuver. And that's your indication. They're kind of like the canaries in the coal mine. They can't Valsalva. They feel pain. And I shouldn't say they can't Valsalva, but they cannot do it intentionally, because what happens is they eventually do clear their ears. They Valsalva by accident, often kind of provoked by the crying. So that's really an issue of the importance of a Valsalva maneuver. Now, it also comes into play in the thoracic cavity. Now, how would that happen? Well, remember we said that we're talking about closing the glottis, and you can increase the pressure, the intrathoracic pressure, and by doing that, you also can increase the intra-abdominal pressure. And so pilots of high performance aircraft do this in order to keep the pressure higher, um, to keep the blood up toward the brain, so that if they're in a high G maneuver, which happens, say, pulling out of a dive or on a high speed turn, uh, this combined with some other devices that they have devices that actually squeeze their legs. It can kind of be like acting like they're trying to excrete bowels, trying to go to the bathroom. But when you do that in a high G maneuver on a high performance aircraft, that has the effect of helping to keep the blood up in your brain, so you don't experience high G syncope. It's called, meaning syncope is a loss of consciousness. Um, you don't have enough blood up in the brain in this case, and you could pass out. And this is one of the things that they do. But in a normal environment, when you're not in any kind of high performance thing, you can also use this. This can increase the pressure inside the thoracic cavity. And that can have the effect of temporarily um, reducing the venous return to the right side of the heart. So how does that work exactly? Because it's important to talk about that, because that can be useful in evaluating cardiac murmurs sometimes. Well, in order to talk about that, we should first do a little review of the architecture of how blood actually moves around between the body and the heart. Um, Sorry if this is review for some of you, but this is for everybody. We have 4 chambers in the heart. There you have the two upper chambers, the atria, the right atrium and the left atrium, and there are two lower chambers, the ventricles, which do the pumping. Although the atria do a little bit of pumping just to help get blood into the ventricles. Let's start with the right atrium. Blood enters the heart after traveling through the body through two big veins called the superior vena cava, the SVC, and the inferior vena cava, the IVC. The SVC is taking stuff from the upper body, and the IVC, the inferior vena cava, is carrying blood that has gone through the lower body. And they come into the blood comes into the right atrium, and this is when the atria are relaxing. And it comes in passively. And then what happens is there's a valve which allows blood only to go in one direction, which is from the right atrium to the right ventricle. That's the tricuspid valve that opens up, and most of the blood that's in the right atrium makes its way into the right ventricle, and then the atrium contracts and gives what's called an atrial kick, gets a little bit more blood out of there to increase the amount of blood that's moved into the right ventricle. And then the ventricles contract, and the right ventricle pumps blood through another valve called either the pulmonary valve or the pulmonic valve. It means the same thing. That sends blood into the pulmonary artery, which divides into two branches, one going to the left lung, one to the right lung, and then they keep dividing and dividing, sending blood through the lungs, where the blood off gases the CO2, the carbon dioxide that's in there, and also replenishes its supply of molecular oxygen, meaning O2. In venous blood, the saturation level of oxygen is typically somewhere around 70-75%. That's the blood that in those nice little artistic animations, they draw that blue. And then when it gets oxygenated, if it's getting a good oxygen supply, and if there's a good ratio of between the locations and pressures of where the blood is actually going, in other words, what's called the VQ match, the ventilation perfusion matching. If there's an optimal matching between the parts of the lungs that are getting perfused and the amount of blood flow, you really get good oxygenation. Sometimes when it's not working right, you get what's called a ventilation perfusion mismatch that causes not enough blood to get oxygenated, and then you don't get as much oxygenation. And there are plenty of other reasons why you wouldn't get much oxygenation. If something's wrong with the lung tissue itself, like pneumonia, or any kind of inflammation, as happens in COVID-19, tuberculosis. We could just go on and on with diseases like this. But for one reason or another, you could have problems which could lead to inadequate oxygenation. But let's say everything's working normally. Oxygenated blood then comes in through veins after going through the pulmonary tree, and it enters onto the left side of the heart through, usually most people have 4 pulmonary veins, and these are carrying oxygenated blood. And here's an example where veins are the vessel that are carrying oxygenated blood. That's that red blood, that the way it's drawn. And where an artery, like the pulmonary artery, is carrying the deoxygenated blood, which is the reverse of what you normally think of. Another example of that is in fetal life and embryonic life. In the umbilical vein is what carries the oxygenated blood, because that's taking oxygenated blood by way of the placenta from the mother, which has been oxygenated in her lungs. And then going back to the placenta, Those are the umbilical arteries. They're carrying the deoxygenated blood. And it's the same kind of thing with the blood going through the lungs. When you've got blood in the pulmonary veins, that is the oxygenated blood. And that blood comes into the left atrium. From the left atrium, we get the same effect with the movement into the ventricle, and then the atrial kick when the ventricles contract. But this time it's going to the left ventricle because it's coming from the left atrium, and it's going to the mitral valve to get there. And then the mitral valve snaps shut, and the ventricles contract, and the left ventricle pumps the blood through another valve called the aortic valve, and it goes into the aorta. Now, and then it goes through the systemic circulation, the very first branches of arteries that branch off from the aorta are the coronary arteries to nourish the myocardium itself. That is the muscle of, the heart. But going through all these different chambers and valves and such, if something is not working right, it can cause disrupted blood flow, and that's what causes a murmur. And you can hear a murmur if you're examining a patient, if it's a loud murmur, to hear a very soft murmur. And by the way, murmurs are sort of graded with like numbers like 1 to 6. Like if it's like a 1, like you got to be one of these people who was like an expert diagnostician who lived in the early 20th century, where like, the stethoscope, this kind of old-fashioned device that looks sort of like this here, uh, which is still used today. By the way, it's very important still. You can hear a grade 1 murmur. You really have to be good to hear that. But a grade 6 murmur is like you could hear that across the room, like you could be a light year away almost, and you hear a grade 6. And then there are all kinds of intermediates in between going from 1 to 6, which we don't need to get into that. But you get a disrupted blood flow, and that's what will cause this. And there are other places you can hear murmurs beside for the heart, in the great vessels. And when there's a connection, there's a classic one in something called a patent ductus arteriosus, which is a blood vessel connecting the aorta, which is that first big artery that comes off of the left ventricle to get blood through the body. There's a connection that's supposed to be there in the fetus called the ductus arteriosus that channels blood from the pulmonary artery into the aorta. But then after birth, if it remains open, there's still that connection there, but it goes the other way. It goes from the aorta to the pulmonary artery because the pressure is higher in the aorta normally. And you get what's called like a machine murmur, which I like to equate it to those horrible, terrible, that should be uh, banned forever, the leaf blowers, the kind of leaf blowers that make doing a recording like this horrible should they come by the window with those machines going up and down, to see up and down. And with that kind of machine murmur, let's call it the leaf blower murmur, in a patent ductus arteriosus, you always have a murmur, which is different from almost all the others, where you actually only have the murmur during what's called systole, the the part of the cardiac cycle when the blood is pumping out the blood. Or you might have it, in there's certain types you could have during diastole also. There are diastolic murmurs and there are systolic murmurs. But the point is that this is a case where you wouldn't have it either during systole or during diastole. Just to sum that up, systole is when the ventricles are contracting, sending blood left, sending blood throughout the systemic circulation of the body, and the right ventricle sending it through the lungs. Diastole is when the ventricles are relaxing and the atria are contracting. And other than a few cases like looking at certain blood vessels throughout the body, including a patent ductus arteriosus, you get these murmurs kind of in and around the heart. And very typically, they have to do with problems with the valves. Either a valve is too narrow, that's called stenosis. And so the blood is not moving with the same hemodynamics that it usually is. It's too much blood trying to go through, so it goes faster to get through there. And if you're talking about one of the valves that regulates blood flow from a ventricle into the artery into which it moves, like from the right ventricle into the pulmonary artery, which is to say through the pulmonary valve, or from the left ventricle into the aorta, meaning through the aortic valve. If the valve is stenotic, you're going to hear that during systole when the ventricles are contracted. If it's one of the other valves, either the mitral valve that regulates blood flow from the left atrium into the left ventricle, or the tricuspid valve, which takes you from the right atrium to the right ventricle, that you would hear during diastole. Now, the opposite is true in the case of when you have another type of problem with the valve, which is insufficiency, also called regurgitation. As opposed to there being a problem with stenosis where the opening through the valve is narrow, here you have a problem with the valve leaflets are not closing behind the blood that has just moved through it, which is supposed to allow just one way of blood. And that way, so if you have, let's say, aortic regurgitation, that means in the aortic valve, after the left ventricle has contracted to push blood through the aortic valve and in the aorta, the leaflets don't then shut the valve, and there's backflow from the aorta into the left ventricle. You could have mitral regurgitation, so there's backflow when the ventricle when the ventricle contracts, there's backflow into the left atrium. With aortic regurgitation, the backflow takes place after the blood has moved through the aortic valve. So it's after systole, meaning during diastole. So it's kind of the opposite. More commonly, the problems are with the aortic valve and with the mitral valve. So those valves on the left side. But there's also other ways you can have murmurs. You can have it because you have problems with the septum, like the walls between the ventricle, the wall between the atria. Those cause murmurs during systole. And there's a condition called hypertrophic cardiomyopathy, which is this horrible kind of cardiomyopathy that classically affects like young people who are in like otherwise in very good shape, athletes who exert themselves and they become, especially if they become dehydrated, then this can often lead to sudden death or something that's like a heart attack where they almost died. There is a murmur that happens during systole. And this is where the Valsalva maneuver is going to come in, because if we compare, let's say, the kind of murmur you get during aortic stenosis, which is something that actually affects different populations from hypertrophic cardiomyopathy, HOCM, but the murmur is otherwise at the same time. It's during systole. But the reasons for the murmur are different. In the case of aortic stenosis, the murmur is because there's this stenosis, narrowing of the aortic valve. In the case of hypertrophic cardiomyopathy, the murmur is because the myocardium is hypertrophied. There's too much of it. And there's so much of it that the septum, which is also made of muscle mostly, kind of balloons into the left ventricle. and there's no room for the blood. So there's a narrow passageway through that left ventricle. Consequently, there's a murmur there during systole. But you could control that murmur by changing the amount of blood that comes into the left ventricle. That's called changing the preload. And that, of course, is affected by how much blood comes into the left atrium, which is affected by how much blood comes to the right side of the heart. Basically, how much blood is coming into the heart in the first place. And remember, we said that doing a Valsalva maneuver temporarily will decrease the venous return to the heart. And if you do a Valsalva maneuver, or you have, say, a patient or someone you're examining do a Valsalva maneuver, if that person has a murmur present during systole because of hypertrophic cardiomyopathy, well, what's going to happen to that murmur? The reason for the murmur is that the ventricle is kind of all pushed together and there's not much of a narrowing. There is a narrowing, there's not much of an opening. And so by letting more blood come in, you're actually going to push it open. And that's going to reduce the amplitude of the murmur. The murmur is going to be softer. And that would be a way to distinguish hokum from aortic stenosis. Why? Because guess what? The exact opposite will happen if a murmur during systole is caused by a stenotic aortic valve. Because the reason for the murmur with aortic stenosis is that there's not enough room for the blood to come through, but the valve is rigid. It's you have calcification on the valve. It's a similar process to atherosclerosis. The same kind of people get aortic stenosis as who get atherosclerosis, meaning atherosclerotic coronary artery disease. And when you decrease the amount of blood flow through the heart, the murmur is going to get softer. In the case of, what did we say? In the case of hokum, when you increase the amount of blood coming into the heart, you are going to lessen the murmur, and that means the murmur itself will get worse when you do a Valsalva, because by doing a Valsalva, you are decreasing that blood flow through the heart, and so the ventricle, there's nothing going to be pushing the ventricle out. It's just going to squeeze in on itself. Did I say that correctly at the beginning? I don't remember. But so let's go through it now just to be absolutely sure. With aortic stenosis, if somebody does a Valsalva maneuver, because you're not going to have as much blood coming through because you've reduced the venous return to the heart, the murmur will get softer. In the case of hypertrophic cardiomyopathy, if you don't Valsalva and if you do something else to get more blood into the heart, like doing, say, squatting, which will actually temporarily increase the venous return to the heart, there's going to be more blood coming into the heart. While that would increase make a aortic stenosis murmur louder because more blood moves through that valve, it does the opposite with hokum. Because you're expanding the heart, the left ventricle is kind of flexible, sorry. That opens up the left ventricle, the murmur, it gets softer. But if you do a Valsalva maneuver and you have hokum, then you're reducing the preload, you're reducing the amount of blood coming into the heart, and the murmur is going to get actually louder. And so that's an example of how you could use a Valsalva maneuver to evaluate a murmur. Do you absolutely need to do that? In reality, no, you end up doing everything with echocardiography. It's kind of an ultrasound on the heart. So these things are not as important as they used to be, but they can really give you a good clue. And before we end, let's just, drive home this point that squatting does the opposite of what a Valsalva maneuver does. So if you think about the effect on the murmurs, any murmur having to do with any kind of a valve, okay, they're all going to work the same way. Anything that's going to cause a louder murmur during in the aortic valve is going to cause a louder murmur in the mitral valve, or if the mitral valve is the reason for the murmur, because all the valves, the murmurs are caused by you've got blood moving faster through it. So more blood moving through gives you a louder murmur, or you have blood moving backward through it, which is never supposed to happen. And that's also worse if you have more blood. Although with the backward movement, it also has a lot to do with afterload. So this can get rather complicated. So you can, that's different from hokum, where it's how big the left ventricle is. All right, but you can actually do the opposite, have the opposite effect of Valsalva maneuver by squatting. Because while Valsalva maneuver reduces the amount of blood coming into the heart, reduces the preload, that you could increase the preload by squatting, squatting the legs. And what that'll reduce the amount of blood coming into the right side of the heart and therefore going through the entire heart. Now, this stuff could also can change if you have problems with the pulmonary circulation, where you could actually have differences between the amount of blood flow on the right versus the left. If you have shunts between the left and the right, so it can get rather complicated. But the take-home message here is that Valsalva maneuver, which is this, that will increase the pressure in the thoracic cavity, decreasing the venous return, and you could utilize that to evaluate murmurs and stuff. And then the opposite of that is a maneuver of squatting, because that increases the venous return. And there are a lot of other maneuvers, but that really kind of goes beyond the scope of things. And on this note, we can kind of wrap it up here. And we will be talking about pressures more than you can imagine. This is just the tip of the iceberg, and we can stop it right there at Astra. Maybe I should do this too.